Good evening, and thank you for joining today's EVOX Neuroscience webinar. Tonight, we will be having a grand rounds review on memory loss using the EVOX system, as well as other tools at your disposal. Before we start, you will notice we launched one poll. I am going to launch one more quickly here. We're going to give people a couple more minutes. And we're going to use the poll data to help not only direct maybe some of tonight's commentary, but also guide future webinars by EVOX Neuroscience. So again, as we give another minute or so for others to join, just take a look and reply to the next poll, which I'm going to post in just a second. All right, everybody, let's get moving along here and start our webinar. We are joined by Dr. Dave Hagedorn, and he's the founder and CEO of EVOX Neuroscience. Before Dr. Hagedorn takes over, I just want to take a second to direct your attention to the GoToWebinar application and point out the questions panel. You do have the ability to submit questions. At the end of the webinar, Dr. Hagedorn will certainly take some time to answer these. So simply enter your question there and click send, and we'll answer as many questions as we can. With that, I am going to turn it over to Dr. Hagedorn. Dave, the floor is yours.
Great, thanks, Andrew. I'm hoping everybody can see the slides okay and hear me. If you can't,
we can see them and hear you, Dave. Thank you.
Awesome, sweet. So what we're going to do today is kind of talk about electrophysiology, so, as it relates to early detection of memory loss, and make you more comfortable with several electrophysiologic measures, both from the science support and what does it look like clinically, what do these values look like if you get them on a report, so that you're not like deer in the headlights the first time you see this type of output, that will become more familiar to you, and you'll know what it means, and feel very comfortable that it's backed by really good research, and that's been around for a long time, and that's the goal for today. So we'll just start out real quickly. The 2020 report from the Alzheimer's Association, was highlighting that nearly 90% of the primary care doctors are anticipating and already seeing pretty notable increase in dementia cases amongst their patients. And there's about 5 million Americans that already have Alzheimer's or some very close variant, with the expectation that this is going to quadruple, minimally triple by 2050. So it's an issue that every provider contends with, family members contend with. It's obviously it's a big burden economically, but we're here for patient care, and we want to try to identify as many cases early as we can, because they are in many cases reversible. And that seems to be a new concept. In the past, we didn't think that was the case. Once you had it, it was just a slow burn. But now we really are aware that some of the underlying etiology that produces the symptom we call dementia, in many cases can be halted, slowed, in some cases even reversed. We've seen that in our office here for sure. It's very exciting when it happens. So subjective memory symptoms are common, and one of the jobs in early triage, early assessment, is to figure out why they have the symptoms. And it could be multifactorial, can be from a depression, can be from hypoestrogenic condition, number of things. We've seen cases even when people had very high doses of statin medication, and when that's lowered, or in a few cases even stopped, the cognition improves. So it's got to have a throw a wide net at why people have the symptom, and having good measures at your disposal helps do that. More than half the older adults complain of memory difficulties and are worried about it. I just recently did an evaluation on some 90-year-old twins. They were a real trip in the office for sure, and they were more concerned about memory difficulties. They had some, there were a few things to adjust with them, but neither of them had a degenerative condition. But it's still a topic that was on their mind, so they spent a lot of money to get a full workup. And more and more patients are interested in doing that. The place for primary care is important to keep in mind. And when I say primary care, that's not just limited to family practice, internal medicine, cardiology, OBGYN, they're all practicing primary care a lot of times for their patients. And they're the first line when people bring up, I'm not really remembering people's names, or I'm getting lost that I didn't used to. They're the doctors that typically hear this first. And then many times a referral onto neurology is appropriate, but there's also a lot that can be done at the primary care medical care level before that referral, which I think makes a better referral, in my opinion. If there's a little bit more lab work testing done early, you can try some things and then pull in your other specialist colleagues, as indicated. When people have looked at this issue and they've polled patients, we're looking at about 12% overall of samples are saying that they're having memory problems, and from the research done a couple years back. And those people that are living at home over age 65, who are complaining of memory problems, it's almost it's about a quarter, and a smaller percent have a diagnosis of dementia, of course, but good number of people are having symptoms, and that doesn't necessarily mean they have mild cognitive impairment, doesn't mean they have a degenerative condition. It just means they're having memory related symptoms, and it could be for a number of reasons. We see it with testosterone levels being quite low, for example. There's a number of different causes for the symptom, and that's the job of the physician to try to sort that out and what's reversible and what's not. So a couple of reasons why we want to push assessment, and it sounds biased because we're a company that makes equipment to look at this, and I just want to make a point that the reason this company even exists is because when I was seeing a lot of patients for the Navy, we didn't have all the tools at our disposal, and we wanted to check things early, and we looked at electrophysiology as being helpful, and that's really the genesis. It was out of a clinical need to try to take advantage of what the research was screaming, that you can catch people as young as 45 already with early onset dementia, and you can do so reliably. And if you can catch them early with the right testing tools, then there's something you can do about it. Now, years ago, we thought that what you did about it was prepare the family. Well, now we know that's not really enough. We can do a lot about changing the underlying etiology in some cases. Even though when you have an APOE4 hit from both parents, for example, that's not a death sentence, so to speak, for Alzheimer's. It does increase your risk, but we have patients that have that but can still overcome the symptoms with care. And being able to catch things, decade, 2 decades early, that's helpful. It's as if you have a ship heading towards the rocks, and the sooner you can turn that rudder, the better chance you have of missing the rocks. And that's the analogy we try to use with respect to early detection. Again, hormones, we look at different type of toxins, environmental, cardiac issues that can be problematic, different inflammatory conditions, rheumatoid, diabetes, etc., thyroid problems. A lot of these other medical conditions are all on the radar when you're trying to evaluate a patient with cognitive impairment. And I'm going to do a shout out to Dale's approach, Dr. Bredesen's approach. He's gotten some good press, some bad press, and I'll have to tell you that I think he's really onto something. We've seen that method be effective. It's a lot of labs, it's a lot of additional tests, but when you have all that data at your disposal, it opens your eyes to a lot of possibilities for cause. So I happen to promote that approach, and there's others like it and that are coming in development right now. But in principle, they're all the same: is to look under more rocks, look under a few more areas, just to look for red flags that could be contributing to the brain's having some pathology that's presenting with abnormal symptoms. The things that we're all typically used to seeing, for decades, we've been using different type of test instruments in the office, short versions mostly just for time saving. But the mini mental status test has always been the standard, and it's got okay statistical specificity and sensitivity, but not as good as other measures. And typically, if you have a person that meets the cutoff, the mini mental status, they're pretty far along with their disease state at that point. So by the time it catches it, it's almost kind of late. So it's not my favorite one. Do I still use it? Yeah, I use it, but I use it in conjunction with other tests. So I don't like its sensitivity. It misses too much. It's not sensitive enough to early onset cases, and the research bears that out. But things like EVOX potentials with N200, P300 are just so vastly more sensitive than this instrument. So I wouldn't throw it out, but I would use it with a grain of salt. It certainly wouldn't be my only measure. Tests like the clock drawing test have some good sensitivity as well, and they're useful. So that's one of the reasons I like this next test, the MoCA, because it has the clock drawing in it as well, and it also has a good many of the items that are in mini mental status. So you have a pretty fast test. It's got a good cutoff of 17. And if you get a cutoff of 17, you clearly can catch the dementia. What I like about it is you can see when a person takes it where their problems areas are very quickly. Is it in the visual, spatial, executive region of the brain? Is it, do they have more areas of difficulty just in attention? That indicates probably frontal, central, anterior cingulate problems. So having this type of instrument at your disposal is helpful. It's also very sensitive with Parkinson's patients as well. So we like this one. The clock drawing feature of it is nice, especially the cube drawing test is also very helpful. And the statistics around it, are certainly better than the mini-mental status. Another one to not overlook is a test to try to look at depression. And in older adults with depression, it's not uncommon for the predominant symptom to come across as dementia. And it has fooled far too many clinicians over the years. And it's a very sensitive and specific test for depression. We also know that people who do have dementia also have comorbid depression as well. But it helps not ignore those symptom variants around depression and mood disorders. So particularly not missing something like suicide, for example, is also captured on this very short, very fast screening test that we always include when we're doing a workup for people with some complaints of memory loss. So I just want to mention that that's a very useful add-on to a simple battery. But the memory assessments using electrophysiology, that's a big step forward. Having the ability now to use what was typically only available in the lab or only available to the neurologists, the specialists that do EEG essentially all day, every day. But to have some simpler tools now that take advantage of some of that technology in a primary care office is a game changer in a lot of ways. It certainly has changed our practice over the last 25 years. And people come just for that purpose because they want that type of testing. And we have this tool now, the electrophysiology, that we marry with the other tests. It's not we do it in place of, it's a combination of the two. And of course, using a pretty thorough lab battery as well. And the researchers are pretty clear and consistent that the EEG is going to, at minimal, be a supplement to the screening tools for dementia, and most likely overcome and replace some of them. And one of the reasons why, I guess, is it's very sensitive and specific. It's non-invasive, so you don't need any radioactive dye or anything like that. It's a good detector of abnormalities. It can help you source localize to locations in the brain that may be areas of focus. It's relatively inexpensive, and it's becoming more and more portable. The research on combining the resting state EEG and event-related potentials is growing quickly. And particular evoked potentials, the ERPs we're going to talk about today, the P300 namely, really helps you get a much higher degree of sensitivity and specificity for looking at, is this a normal person, older adult? Is this really mild cognitive impairment? Or can we even discriminate between an Alzheimer's and mild cognitive impairment? In using these tools, it gives us 90 to, in some cases, closer to 100% of accuracy in making that determination. Of course, it's very nearly impossible to get 100%, but when you're in mid to high 90s, that's a very, very good tool for sure. So when we're looking at EEG, typically you're using 19 channels. That's considered a full international array. Having that distribution, that 1020 international system distribution over the scalp is important because there are normative databases that use all those points, and the research from around the world is all talking about the same place and the same measurement. There are some systems on the market that have fewer channels, but 19 is generally considered, the standard. Now you can go way up, and in research labs you go up into the hundreds of sensors. But for practical clinical use, 19 is plenty. and you can do good source localization with 16 and 19 channels quite readily. And one of the benefits of that is with that data, you can start to determine which brain area is more normal or abnormal. And when you're looking at the brain mapping, it can help clue you in to where the problem areas are. For example, I saw a person a celebrity who was told that he had Alzheimer's, and with the brain map was really quite clear. He had, left frontal temporal excess beta overactivation, so it was a frontal temporal type dementia, but it appeared to be to chronic temporal arteritis that was also caused of inflammatory disease in the neurons themselves. So we had inflammational problems in the front left part of the brain that was causing a lot of symptoms, mood symptoms, as you might guess as well. But having the ability to have the EEG data to look at that and to source or localize where it's coming from was very, very helpful. And it looked very different than what typical Alzheimer's would look like. So the three things I want to just kind of camp out on today for early detection for markers, and they're not really called biomarkers. Biomarkers is a technical term. To meet that definition is quite a leap forward. So we call them, red flags. They're correlational markers. They're strong indication markers. But to be technically correct, you wouldn't really call them a biomarker, even though they're still biologic. So that's more of a term that has a different meaning. But they are very, very useful, and there's a lot of research that supports these. So we're going to talk about all three of these for the remainder of this brief lecture. The peak alpha frequency, okay, it's also called posterior dominant rhythm. There's different names for it. We're generally looking for the highest amplitude between 8 and 12 hertz, and it's measured in the back of the brain, typically with the eyes closed. Generates the dominant alpha rhythm in most people. There are some people that do not produce that, or it's not high enough amplitude to record. Doesn't mean there's something wrong with them. It does happen as a normal variant, but most people you'll see this rhythm. And then there's the P300 evoked potential. And there's P300A, there's P300B, and we're going to talk about those because they're measured at different places on the head, on the scalp, and they have different meanings. And then last, the EEG. The frequency of the EEG can be digitally analyzed to produce images. And with those images, it helps you see where there might be a frequency abnormality. And we typically look at the power spectrum of the EEG to see how much is normal and how much is abnormal. So that's what we'll take a look at now, one at a time. So let's start by basically what is the EEG and what is the power spectrum analysis. So the spectral analysis is mathematics that basically takes and filters the EEG signal. So if you have a sensor on the scalp, you're going to get different frequencies measured at the scalp on the sensor. The amplifier makes it so that it converts digital or analog to digital, so we can do something with that signal. The software can filter out different waveforms and separate them for analysis. And then it can produce something what's called a fast Fourier transform image, which you see in the bottom right. And it shows the amplitude, or how loud or how many neurons are being recruited at that point of measure. Let's just call it at the top of your head, which is CZ, that location. And it says how much amplitude is the system recording at the different speeds, the different wave speeds. And the wave speed has names. If it's a very slow wave, like oscillations per second is hertz. That's what we measured in hertz. If it's a slow wave, anywhere 1, 2, 3 hertz, we have a name for that. We call it delta. That's typically a very slow, sleepy wave, if you will. You have theta is a little bit faster, but it's still considered a slow wave. Amplitude is the height of that wave, and the latency from left to right, that's how many of those occur in a second, is how it gets its frequency name. So if there's 4 oscillations in a second, that would be 4 hertz. A little bit faster, you've got alpha. And I like to break alpha down really into alpha 1 and alpha 2 because they really are different. And the slower alpha, 8, 9 hertz, is really different than that of 10, 11 hertz alpha. And then there's beta, faster frequencies. And again, betas can be broken down into beta 1, beta 2, beta 3, just to chop up that frequency range even further. And you can see in the bottom right, the FFT has that chopped up for you, kind of color coded. And when you have a normative database, you can compare your patient's data to what should be normal. And it's age and gender norms. So if you see where there's an abnormality and difference from normal, that can tell you something. So that's the why digital analysis is so critical if you're trying to take a deeper look at the EEG. Experts that look at EEG all the time can very quickly visualize what that FFT looks like without even having it calculated. They're used to seeing so much EEG that you can just see it in a second when you look at a screen of EEG. Especially if you change the montage, you can start to get an idea where in the brain there's a problem. But not every primary care person has that kind of experience, so that's where the EVOX equipment comes in to provide more digital analysis and images to help provide kind of visual cues to what's going on. So, there are different things besides power spectrum analysis of EEG, but that's kind of the basic entry point to look at the amplitude or the power. And one of the things that we get when you look at that power spectrum is you can see that peak alpha. So this peak alpha frequency, here you can see it on the right in that image, was a little bit faster than 10 hertz. And you can see it's a very large amplitude, pretty sharp peak. It's probably measured at the occipital location on the scalp in the back. And that you'd say this person's peak alpha is somewhere around 10.25 or something like that, be my guess from looking at it. And what's useful about this single measure, about this peak alpha, is it's correlated highly with cognitive processing speed. And it declines or gets slower, so it may go from 10 hertz to 9 hertz to 8 hertz to 7 hertz with memory performance declining. So it's one single measure that has very, very useful applications for tracking patients over time. So you see in the upper right-hand corner that there's a red line I drew across at 8 hertz right here. When you start getting a peak alpha closer to 8 hertz, people are going to start having some memory problems. Typically, the average adult is somewhere near 10 hertz. And you can see as normal aging takes place, it's a slow decline from say 10 hertz, maybe down to 9 hertz. But none of the normal patients really dipped into the troubling zone, which is below 8 hertz. But when you have a patient who has a decline and they're coming in at 6.5, they have dementia. And I've not seen, I don't think, a peak alpha as low as 6 without pretty significant cognitive impairment in an adult who was once functional. And that peak alpha frequency, generally will be stable for most of your life. You're healthy. It doesn't have to dip necessarily. And one of the things we look for in differentiating the type of memory problems people have is that peak alpha. Because if I have a person with depression, for example, or a hormone-related reason for their memory complaints, their peak alpha may be perfectly fine, and so might their P300B. So some of these markers are helpful because they help talk you out of, I don't think this is dementia. I think this is a different reason for memory loss. Okay. On the other side of this, the speed spectrum for peak alpha, if it starts to get north of 11 hertz, 11.5, you see those people having some trouble with the OCD and anxiety, particularly if their eyes closed alpha goes up and their eyes open alpha, say, is at 10, and they close their eyes and their peak alpha is like 12. We often see that in PTSD. So it's a very overactivated central nervous system with PTSD, and when they close their eyes, there's no input that kind of protect themselves about what might be coming. And we often will see very, very consistently, I've tested, I don't know, maybe a couple thousand people with PTSD already, and I see it very consistently as a marker. So a fast posterior peak alpha in a person, as it differs from eyes open, eyes closed, is pretty classic. But again, the slower peak alpha, okay, you will see a correlation with memory performance. And below 8 hertz, it typically starts to correlate with mild cognitive impairment and even with Alzheimer's disease. I'm going to throw this little chart up because we put together this some time ago to show what is a normal pattern from when you're born of the development of that dominant rhythm, that peak alpha. And it starts to really climb up to the normal level in the first few years of life. You can see by the time a person's 12 or 13, their alpha is pretty much set at where it's going to stay for the most of their life. And if it dips, then there's a problem. It's clinically a problem. But you wouldn't expect a 3-year-old to have a peak alpha of 10. That would be atypical. So these scatter plots are reflective of a study that was done, which shows the relationship between that peak alpha and a couple tests. The reverse digit span is, as you may recall, is if you're asking the patient to report back a set of numbers that you give them in normal order. We say 1, 5, 7, 9. And then they're supposed to repeat back to you those numbers reverse, 9, 7, 5, 1. That's a reverse digit span task. And it's a more difficult task for people with dementia. And the relationship with, we know that the peak alpha frequency drops with age. This is normal aging on the upper left side. That's a normal decline. Nothing really pathologic except maybe one of these outliers here. And we also see that the reverse digit span score also declines with age. Okay, and again, these are with healthy people. And the one on the right shows the relationship between that cognitive task and peak alpha. And if that cognitive task is performed poorly, you have a low score. You only can report, say, a couple items back. That has a correlation with your peak alpha. So it's another nice test, nice study that clearly shows that your peak alpha is a good single numeric measure of cognitive processing, and because the reverse digit span test is regarded as one of the more robust cognitive processing tests. Now, when they've looked at peak alpha with different types of dementias against controls, so they looked at vascular dementia, Alzheimer's, and normal controls. And they found that the peak alpha with a normal control stays about 10 hertz. In this case, the average was 9.9. And with the Alzheimer's disease patient population, it was at average of 8 hertz, so it's about 2 hertz slower. Similarly, the vascular dementia was about 2 hertz slower, but the difference was in the amplitude. We see the amplitude not only of that slow alpha-1 being higher than normal in both vascular dementia and Alzheimer's, but delta is significantly higher. And delta is this column over here between the 0 and the 5. So this 2-3 hertz amplitude is notably elevated in both dementias compared to normals. And that's the EEG portion that we want to focus on as well today, not just the peak alpha, but in addition to that peak alpha measure. So one final note about peak alpha is it's used in different kind of global deterioration scales. It's used when people have put together different algorithms for, what measures do you put into an algorithm that would be very robust. And in general, with dementia, we see more delta and theta, like I just showed you on the prior screen, and we see a lower overall alpha amplitude and a lower peak alpha frequency. So these are some of the features that you'll be looking for in your early assessment of patients with memory complaints. So let's jump over to EVOC potentials. So we've kind of camped out on peak alpha for a little bit. Now let's flip over and talk about ERPs. So what is an ERP? So an ERP, again, is recorded from the EEG. So you're collecting the EEG on the scalp, and it's time locked to stimuli, certain stimuli that are presented on the screen or that you hear, see, and the computer is able to record the exact milliseconds of EEG activity at the moment of that stimulation and following. So we generally look for about a second after the stimulation, which is 1,000 milliseconds. And what it represents is the small voltage generated in the brain, and it's in response to that specific stimuli. And the stimuli that the EVOC system uses is something that I studied for quite a while and worked with John Polich on, because the auditory stimuli was difficult for a lot of our patients that had hearing aids and had some difficulties with hearing. So we went with a visual version of a large circle and a small circle. So whenever they see the large circle, they're supposed to recognize that as a target stimulus and press the button. And that's a more higher cognitive task. And that helps us generate what's called the P300B. And then we have a number. We have the average brain neuron cluster firing, this batch of neurons that will fire all at the same time, recorded up the pyramidal neurons to the scalp, and we record when those all fire in mass. And we can tell how many milliseconds after the stimulation is presented do those neurons fire, okay? And we record both the amplitude, or how much energy is produced by all those neurons firing, and how long it takes post-stimulus, which is called latency. So there's other types of ERPs, not just the P300 here, which is this top one, but there's also the N200, which is a negative deflection. Again, these have to do with polarization and depolarization of neurons. But we look at early precognitive measures, like a sensory measure, be in the 100 range, whether it's the P100 or an N100. And even the 200s are somewhat sensory related and precognitive. They're kind of in between. So it's definitely in the cognitive domain for recording when you're out at 300, 400 milliseconds. And there's been a lot of talk for a long time about ERPs. I mean, it's staggering to me as a neuroscientist and clinician that we've had this stuff around for 50 plus years, and it's not new technology. ERPs have been in wide use for a long, long time, in the early 60s and before. And they said back then that they would become a primary tool of cognitive neuroscientists. It just took a long time to get it into the clinicians' hands and into residencies. But when I teach at UNC and then previously taught for family medicine, emergency medicine residency, and we included ERPs in our training because I want the new physicians to learn about this technology. So yes, it's a very useful tool. It's been around for a while, and despite, it's inexpensive, it's non-invasive, and it's a great thing to add to other fantastic medical tools that already exist. So ERPs, they allow us to measure cognitive operations from before that sensory stimulation and beyond. And that is a very useful tool to get an idea about cognitive processing speed and where in the brain there may be problems, because you can record ERPs anywhere on the scalp you wish. And what we do is we average each of those events. So we have a stimulation here on the bottom left, that's the EEG. Then there's a break, that's another stimulation, and the computer then basically overlaps these time lock segments and averages them to produce one single smooth wave. And that would be one location on the scalp where you would record that. So if it's, say, central parietal, it's called PZ, you'd be recording that location. Is a typical location when you're trying to record a P300B. So event-related potentials, they capture the neuronal activity related to that sensory stimuli and the cognitive processes related to that stimuli. And, excuse me, we're looking at the latency, how much time it takes post-stimulation, and the amplitude, which reflects the amount of neural recruitment. So both numbers are important, and they're both important for dementia in particular. Again, the P300, we like that measure. There's a lot of research supporting the P300 measure, and it's roughly in the 300-400 millisecond range. Some people ask, well, why isn't it exactly 300? It really depends on the stimulation type that you're using. There are some tasks where normal would be close to 300. Other tasks, normal might be more like 350, 380, depending on the type of task that you're using. So you should always ask, what is the stimulation task? Where is the sensor placed on the scalp? When you're reading research, those are two important things, so you're not comparing apples to oranges. You can compare apples to apples. So the speed is latency, the amplitude is power. Those are the types of measures you're interested in looking at, because people with cognitive impairment may produce next to no amplitude at all. The research is pretty consistent here as well, as just similar to the peak alpha research. You have another scattergram type statistical design visual here to explain this. So the one on the left is the P300 latency, which shows that the latency gets longer, means it takes more time. It goes from 300 milliseconds to upwards of 450, 500 milliseconds as you get older. And again, that would be a normal pattern with age. Just your chronicity is just your age. But if you have pathology, then the latency could become quite long. You could have a P300 that's, say, 700 milliseconds or non-existent. That would be pathologic. The amplitude also is a marker that declines with age. It gets lower amplitude. The recruitment is lower, the neuron activity, and that amplitude drops with age. Again, that's measured in microvolts and as a measure of amplitude, and that measure, is typically lower with age, but not pathologically low. So you would see a slight dip, but not something that's fallen off a cliff. So in the P300, we were very interested in these two measures. So the example in blue is normal. So this is a P300, somewhere around 390 milliseconds. You see the amplitude is close to 30. So your latency is, let's just call it 400, and your power or amplitude is 30. And that's normal. What's abnormal in this brown sample is a case of a person with dementia. That P300B is closer to 700, maybe 675, and the amplitude is substantially less, from 30 down to 10. So you have a reduced power, amplitude, and reduced latency or speed. Both measures show abnormality. And that's the sort of thing you'd be looking for in your reports when you're looking at the P300, P300A and B. Now, the P300B is the one marker that's consistently used when looking at cognitive impairment, of the dementia type. The P300A is measured more forward on the scalp over the anterior cingulate, and it's a measure of attention. So that P300A is a different stimulus. It's looking at your orienting response. How well is the person able to just focus and be aware of his or her surroundings? And they don't have to respond to that stimuli. It just happens to them, and are they aware of it? The reason that's important, and the reason we put P3A and P3B in the report, is you want to ask the question, is the person's failure to have memory due to poor processing in the parietal portion of the brain, like with a dementia, or is it that they never paid attention in the first place, so there's nothing to remember? You can't remember something if you haven't attended to it in the first place. There's nothing there to remember. So it's nice to answer those questions. And if I see a more frontal abnormality with the P300A, then I start thinking, is this a frontal temporal dementia? Is this simply ADHD? Is this depression? Is this a frontal lobe injury from a car accident? Those are the types of questions that would come up, versus if I had a P3A that's normal in the front of the brain and a P3B is abnormal, then I'm more concerned about a degenerative type dementia. The P300B is used also to determine if you have a person who's going to progress or really regress from mild cognitive impairment, and if it gets worse. So prolonged latency, so you have a delayed P300B, say it's not 400, it's more like 500, 600. If that latency is getting longer, then that's a predictor of a regressive dementia case or degenerative pattern. And that is a rather consistently used latency. So while I like the amplitude measure a lot, and I think it's important for looking at cognition, the latency is consistently the go-to measure. If I had to pick one or the other, I'd pick the latency number to camp out on. But amplitude also is sensitive, as you see here too. So the amplitude declines with the progressors, and the latency gets longer with the progressors, is what this research has showed us. And what's nice is that when you have these measures early, you have an early indication or a baseline to determine, as the medications or non-medication treatments the person's receiving, is it working? Is the person at least stable? All right, we have longer latency, lower amplitude is consistently shown when you can catch a mild Alzheimer's case. So using these measures, the data has helped us, that the research has shown that we can catch early cases, and that's another fine example of this study here. The sensitivity and specificity of the P300A and P300B are very strong, and Benny's research is one of the researchers who's done some good work here. There are others as well. I just show his because the sensitivity in some cases is as high as 100%. So looking at the P300 latency, which at PZ, which is called the P300B. So if you're at location PZ, that's typically for P300A. He was able to show very, very good specificity from normals versus Alzheimer's, from mild cognitive impairment versus Alzheimer's at 100%. The frontal lobe, the P300 at location FZ, this specificity was 100 for normals comparing to mild cognitive impairment, normals versus Alzheimer's, and you see a bunch of others in the 90, high 80 range, which are quite good. So taken as a whole, looking at the P300A and P300B are very, very useful measures for looking at progression of disease. This is one of our patients who was doing that Dale Bredesen's program, which was quite involved, which I'll show you in a second. But she started out with a P300 of 608. That was a P3B of 608. And it dropped to 512 with treatment over the first couple of months. She was ketotic at that point. Ketosis was one of the things that was found to be helpful for her, but then kind of fell off the wagon, had some problem, had some colitis, was on antibiotic therapy. Her gastrointestinal system, her enteric nervous system took a dive, and she started to then regress. After that course passed, she got back on the horse, and her P300B normalized below 500, which was normal limits, and her dementia was clearing up. In fact, her children from Germany flew out because they couldn't believe it was true. They just said that's not possible, and it was quite stunning. So this is one of the cases that we just happened to pull to show that you could see the P300 is a very useful measure for tracking progress over time. And this is some of the things that we did for her. A lot of enteric nervous system work, some different types of supplements, B vitamins. She had a methylfolate problem, MTHFR abnormality, fixing the enteric nervous system, hormone balancing, etc., dealing with inflammatory conditions throughout the body, that sort of thing was what we did with her. And then finally, in the last few minutes that we have, let's take a look at the EEG amplitude, because as I mentioned earlier, we're going to be looking for excess slowing. So if you've got too much delta theta, you want to see where is it? Is it in the frontal lobes? Is it the parietal lobes? And generally, we look at a combination of these three things when we're looking at EEG analysis. We're looking at that peak alpha. We're looking at that theta. How much slow wave is there? How much is there too much? 3, 4, 5 hertz, because that's a very slow EEG pattern if that's dominant in an awake condition. And beta, is there not as low beta we see in dementia? Now, in some cases, when you have neuroinflammatory conditions, beta can be high, and that can fool you. But if we like to rule it out with blood testing, ANA, and other labs looking for inflammatory markers. Then there's also a ratio, an alpha-theta ratio that's been used, and that also has some good accuracy. And then just behavioral measures, their ability to perform tasks and have reaction time. So a number of measures you can get rather quickly with EEG digital analysis. And here might be a good sample of what healthy looks like. Normal peak alpha of 9.5. You got normal EEG, 3 and 4 hertz is normal. You can see here the P300B is normal. As it progresses, toward the red, you see much more slow activity. 3, 4, 5 hertz is excessive. More delays in the P300B and a decline in the peak alpha. Those are the things you'd be looking for. So in summary, you got the peak alpha you want to watch. You want the P300 measure, the amplitude and latency you want to eyeball. Keep an eye on that. And the brain power and slowing. Particularly, we look at where is there slowing. This person here on the right has got temporal slowing. So maybe this is more of a temporal type anomaly. And with Loretta, you can even source it to more structures, what structures are involved in the brain. Okay. So that's it for that. I'm open for a couple questions. Andrew, feel free to float a couple questions my way if you'd like.
That was great. Thank you. At this time, there are no clinical questions up here. Give everyone about 30 seconds if you did have a last-minute question for Dr. Hagedorn.
I'm always available for, people can email too if they have questions.
Excellent. Well, we thank you all for joining us here, and we look forward to the next webinar that we'll do soon. And as you know, you can email Dr. Hagedorn, you can email myself to get on our schedules for some case reviews. All right. Thank you, everybody. Take care. Bye-bye.
Good night. Thanks.